Okay, great. Hello, everyone. Thank you all for being here in person as well as virtually online. I'm Myra Marayag, and I am with the development team at CalMatters. And so we're so appreciative of you spending a little bit of your day with us today to learn more about this important topic on mental health and California's parity law. So for those of you who are not familiar with CalMatters, we're a nonprofit, nonpartisan news organization, and we cover California policies and politics with the sole mission of keeping our government transparent and accountable. So we have our online website, a daily newsletter, we're on the radio, we're on TV, but there truly is something special when we're gathered in the same room or virtually to hear from experts who are very knowledgeable in this space and will help give us a deeper understanding of the issues. We wanted to thank our convening partners, Center for Nonprofit Management, as well as SoCal Grant Makers for making this event possible. We're going to be doing a series of SoCal events for the next few months. So please join our newsletter so you can be informed of future events that are happening here in Southern California. Again, we're thankful for you spending your time with us at the beautiful Long Beach Aquarium. So in terms of the format for the day, we're going to have a 45-minute panel conversation, and then we'll have 15 minutes for a Q&A for the folks here in the room. And for folks who are watching online, please feel free to send an email to our events email alias, and we will follow up with you after the event. I now want to introduce Jocelyn Weiner from CalMatters, who's going to be moderating this conversation. Jocelyn is our projects reporter with a focus on mental health and healthcare, and explores the intersection between government policies and people's lives. She has worked as a California reporter for more than 2 decades. I'll now turn it over to Jocelyn.
Hello, everyone, and welcome. I'm so glad you all can be here today to join in this conversation about what access to mental health care looks like when you have private health insurance here in California. This is obviously a topic that could easily fill many hours or days or weeks or months or years, but I'm thrilled that we will at least get to spend the next hour together. 4 years ago, California passed legislation that required health plans to provide their enrollees with all medically necessary mental health and addiction treatment. At the time, people used terms like groundbreaking to describe it. But even with all the optimism, there were some who said quietly to me that we were going to have to wait and see how transformative the law actually would be in people's lives. After all, this was not the first time that California and the federal government has passed landmark legislation trying to address the issue of mental health parity, which refers to requiring insurers to treat mental health and physical health conditions equally. The California Parity Law of 1999, the Federal Mental Health Parity and Addiction Equity Act of 2008, the Federal Affordable Care Act of 2010. You may have also noticed that none of these laws led to everyone getting all the mental health treatment that they needed immediately. So clearly, laws alone can only take us so far. Today, we're going to contemplate what all this means for actual people trying to get actual mental health and substance use treatment through their health insurance providers. Have things gotten substantially better in recent years? Are they worse? And where are we heading now, especially in the context of the recent election? I also wanted to note we are having this conversation against the backdrop of a strike by Kaiser mental health workers, the second such strike in just over 2 years. That's now in its 4th week. We're being joined by many NUHW folks. And it is being diligently covered by my colleague, Joe Garcia. So seek him out if you want to talk to him. He's here over in the corner. And I wanted to frame our conversation with a comment that was made to me by the mother of a young man who died of a fentanyl overdose not long after his health plan declined to extend his stay in residential treatment. She told me she remembers screaming and crying over the phone with her health plan, begging them to let her son stay in treatment longer. He wasn't a person, she told me. He was just a number. Today, I'm very grateful to have this conversation with 3 excellent panelists. You will notice a theme about all of these women. They're all amazing, and they have all had careers that give them many different lenses into today's conversation. Elisa Feld is the policy director for the County Behavioral Health Directors Association, where she leads policy analysis and administrative advocacy efforts for counties' behavioral health agencies, including about parity implementation. Before joining the association, she spent a decade working for community-based organizations, providing mental health services to both young people and adults. LaShawn Francis is Senior Director of Behavioral Health at Children Now and a regular source of mine. She previously worked as Associate Director at the California Medical Association, provided fiscal and policy analyses on mental health and alcohol and drug programs at the LAO, Legislative Analyst Office, and worked as a program analyst for the U.S. Department of Education, among other things. And Joan Borston is the CEO of First Responder Recovery Malibu and is former executive director of Summit Estate Recovery Center. She is also herself a former international reporter and has worked extensively in the film industry. Her documentary film about her husband, Oleg, her late husband, is now streaming on Amazon Prime. I didn't want you to have to do the pitch yourself. So. Unfortunately, our fourth panelist, Karis Myrick, was unable to join today because of a family emergency. In our conversations leading up to the panel, Karis offered valuable insights as a person living with mental illness who has also been a longtime mental health advocate. In her absence, I challenge all of us to approach this conversation with particular attention to what is happening in the lives of people living with mental illness and seeking help. And I am going to do my best to leave plenty of time for Q&A at the end, so keep questions in mind. All right, LaShawn, let's start with you. Tell us a little bit from your perspective. Are things getting any better in terms of access to mental health care? What are you hearing from families and kids?
So are things getting better? I think it depends on what exactly we're talking about. So when I first started this work yesterday, we all know, no one was really talking about mental health. We actually used to refer to mental health as the, quote, redheaded stepchild of healthcare. That was a real quote. People jokingly talked about it, and we never talked about substance abuse. I mean, for the most part, substance abuse was your fault, and we weren't going to touch it. Today, particularly because I work for an organization that centers children and youth, kids are talking about their mental health. I mean, that's all they're talking about. If you spend any time on social media, young people are talking about their mental health in ways that frankly make me uncomfortable at times, because that is just not how I grew up. I didn't grow up talking about mental health so openly and so frankly about what my struggles were. So yes, that landscape has changed. Mental health is no longer the dirty word in the room. There's a separate conversation around access and what we're seeing for families to be able to access care. What I will say is the landscape has shifted drastically, because back then people did not want to access care. You were forced to access care for the most part. Now people are willingly calling their healthcare provider and saying, I need a therapist, I need a provider. And frankly, our insurance companies were not prepared for that.
Elisa, I wanted to ask from your perspective, like, what are counties seeing? So you're the public sector. We're talking about private insurance, but I remember back before the 2020 law passed that I was writing about people leaving their health plans, dropping to get onto Medi-Cal because they thought they could get better care through the counties. So I'm curious to know, is this still happening 4 years after SB 855 was passed, and how does it impact counties?
Thank you for that. So I will say, yes, it is still happening. That quote that you said from the mother who lost her son of, my son was a number, not a human being. This is one of the things that makes me very proud to represent County Behavioral Health, because when someone shows up at their door, they don't ask, who pays your health insurance. They see a human being in need and they try to get them that help as quickly as possible. We have largely been able to do that due to the passage of Prop 63 in 2004, redirecting a millionaire's tax to the local level to plan mental health programs. And counties lifted up a lot of programs that were designed to meet the community for those that were underinsured, those that had no insurance, because bear in mind, this was actually 2 decades ago when that we started receiving those funds. Unfortunately, with the recent passage of Prop 1, which is restructuring and diverting $1 billion a year towards just housing interventions, which is very important, we are losing even more funds for direct services. And unfortunately, counties are starting to have that conversation of how do we get you connected to your appropriate provider in the commercial landscape. And that is very challenging. We hear repeatedly across the state from counties that some counties have designated individuals whose sole job is to help people connect to whoever their provider is, regardless of payer. And even despite those really hands-on care coordination, case management, folks are still coming back saying, I can't find anybody. I called 10 names in the directory and no one's taking new patients. Or there's also, particularly in the commercial side, this is where I believe Medi-Cal is very strong, is we definitely have a more diverse workforce. We have a longer ways to go. We can definitely continue to work, but we've also heard that individuals will come back to counties and saying, I can't find a therapist that aligns with my culture, with my native language. And so that is something else that will bring individuals back to counties. And unfortunately, due to new statute, counties are going to be forced to really prioritize the Medi-Cal population and won't be able to do these services that we've been doing now for 2 decades, I would say, serving those on commercial insurance as much, just because of that redirection of the funds. And to answer your question, we do continually hear of individuals anecdotally coming to the county saying, my commercial payer told me I could get better services at the county, and so here I am, serve me. Sometimes they, unfortunately, just due to their mental health or substance use disorder symptoms, decompensate to the point where they are eligible for Medi-Cal. They've lost their employer-based insurance or can't pay their premiums anymore. And so then they do land in the public safety net. And so they are county behavioral health's responsibility to serve. But we even have folks who, who need services who have not gotten to that point where if they had that early intervention, their symptoms could be addressed. They would not progress more. And those are the folks that we are really concerned about falling through the cracks with this shift.
Thank you for that. Joan, you're up. I was hoping you could share a bit about what happens to the people who are seeking coverage for treatment through the facilities that you've worked with, and do they generally receive the insurance coverage for their care that their doctors say that they need? What are the challenges to making that happen?
So I'm from the industry that is called out of network. We don't serve people in network. So we started in Malibu, and we had actors, entertainers, and rich people. And then when we got bought out by a medical investment division of Wells Fargo, because we had a good reputation, we moved to Silicon Valley and turned a failing treatment center around. And now every year calls us one of the best in California, even though we're very small. So we have, especially in Silicon Valley, a lot of Fortune 500 employees who have what we call Cadillac policies. In other words, it's going to pay amazingly, and they're going to be able to stay in treatment, hopefully as long as they need, usually about 28 to 30 days in residential, and then 2, 3, 4 months in outpatient. So it was before the pandemic that one of our colleagues in San Diego, who has a facility called Aton, started complaining that his clients were being denied treatment by unqualified doctors. And I know he was writing letters to Department of Managed Healthcare, He's very demanding, and no one was paying any attention to him. And then when the pandemic started, and we didn't have that problem. When the pandemic started, our 500 patients started getting denials from the same doctors for no reason, and they weren't even qualified doctors. So, as Jocelyn knows, I decided to tackle the problem, and I worked together with 2 billing companies. So, and we started to keep score. Which doctors always denied? Which doctors never denied? And it was pretty clear by the time that a state senator named Dave Cortese came to see us and to see our facility because we were in his district, that there were too many unqualified doctors being allowed to deny. So Senator Cortese said, "Can I help you?" I was shocked because I thought he was going to tell us to send all these Fortune 500 employees to the Salvation Army. But then he said, "I have 38 years, 9 months, 4 weeks, and 2 days," which means he himself was in recovery from addiction. And he turned out to be a fantastic and loyal advocate. So he wrote a bill called SB 999, and it was about not allowing unqualified doctors to deny treatment and just by chance get another 12, 15 assignments where everybody who authorized treatment got 2 or 3. And we successfully carried it through the state legislature, and it got to the governor's desk, and he denied it. We were stunned. And he said that the reason was that the bill that Jocelyn was talking about, SB 855, which had passed, it actually became law in 2021, right, was too new, and the Department of Insurance and the Department of Managed Healthcare hadn't yet written their regulations about it, and he was sure that they would take care of this. So they didn't, and so we had a testimony in October of last year, and the head of Department of Insurance said, "Anyway, we have written regulations that say that the doctors have to be qualified." And the head of Department of Managed Healthcare, which has Anthem, said, "I don't know anything about this," even though I've been writing to her every month for years. And Senator Cortese kind of went after her, and she said, "Oh, it's too late for me to do anything for you." So he brought SB 999 again. And so, as usual, we had one of our alumni who'd been impacted come and testify. And we passed the Senate Health and the regular Senate and Assembly Health. And then it went to a committee called, what do you actually call it? Yeah, they call it appropriations. And somehow Department of Managed Healthcare had put this huge cost on what it would cost them to tell doctors who are unqualified not to deny. To stop denying. Actually stop taking the job. So I don't know. The governor gets a lot of money from Anthem. Maybe I'm wrong, but there seems to be whatever. So that's like the kind of problem that we deal with on a regular basis, and that's for people who have really good employer insurance.
So let's talk a little bit more about the state regulators and their role. There was a study that came out in 2023 that found that less than 0.2% of people who were denied mental health treatment or any treatment filed an appeal with their health plans, and even fewer of those go on to appeal to the state. But it seems that a significant part of how the state regulates is based on these complaints. So, LaShawn, I was wondering if you could talk a bit about the role of the State Department of Managed Healthcare playing in getting plans to ensure to comply with the law, and maybe as part of that, you'd like to delve into the legislation that Children Now sponsored to trigger automatic reviews.
Yeah, I think the first place that I want to start, though, is how Children Now even got involved in this conversation around health insurance approvals, right? Because it is a very boring topic. I know all of you are here and you're riveted, but for the most part, when we start talking about health insurance denials and coverage, people's eyes just kind of glaze over, right? They just shut down. But
Until it happens to them.
So we got engaged because I kept hearing from parents who said, yeah, we have employer-sponsored coverage, but one of us are going to quit our job so that we can qualify for Medi-Cal. And up until that point, most of my work and advocacy had been in the Medi-Cal, Medicaid space. And I said, well, why? And there's a few reasons. Under Medi-Cal, you have what's called the EPSDT coverage and requirement that essentially says if you are a child and you are in need of anything, you can get it. How that works in reality is a separate conversation, but what that really means is that if you are on Medi-Cal, very rarely are you getting a letter in the mail that says Medi-Cal will not cover X for your child. They might say you have to wait 6 months to get that thing, but they're not saying no. So there might be delays, there might be network issues, but they're not saying no. That's very different on the commercial side. For employer-sponsored coverage, they can say, this does not meet what we consider to be medical necessity. This does not meet what we consider to be urgent care. This does not meet what we consider to be, what's the third one? Prescription drug coverage. And we took a deeper look at that. And we said, well, why is this happening? How is it happening? And why is no one talking about this? And my friend is right. This actually does create a burden for counties, because what ends up happening is counties just catch these people when they should have had adequate coverage on the commercial side. And I realized a few things. One, we have no idea how much commercial plans are denying care. No idea. They are not required to report it. No one knows. So when I said this was a problem, government officials said, prove it. And I said, well, I can't prove it. You should be asking for that data and information. How did that now become my job? So I can't prove it. All I have are the stories, right? The stories of the parents who say, this has been a problem for me. Unfortunately, stories are not as compelling because they tend to sound more individualistic and not like a mass problem, right? So we said, look, we know this is happening. We're talking to parents, we're talking to families. We should not be creating a system that provides more strain on the public system that is supposed to catch the neediest of us all, because the commercial companies, the commercial plans that have the resources are simply saying no. And they're saying no because they can. And there's no one to challenge that. What the Department of Managed Healthcare has set up, they've said, okay, great. If you're told no and you disagree, you get a chance to appeal. But the way you appeal is you call your health plan first and you file a grievance with your health plan. And this is supposed to be on all your materials, right?
Twice.
And if the health plan says no, again, then you get to call us, the state, and we'll look into it for you. The good news is when that happens, almost over 75% of those denials get overturned, which means the health plans were in the wrong the first time that they denied your care. The bad news is very few people call and complain because they don't know about it. And those that do overwhelmingly speak English. We live in the state of California, so I don't even have to tell you why that's a problem, right? So we're seeing language disparities, right? When it comes to who even knows how to go about being aggressive and being able to be an advocate to get care for their child. So that's how we even got here. That's the role the state plays. We ran a bill that was very simple. We said, if you deny a children's mental health or addiction service health plan, you have to review it without the parent having to call. You would have thought I called for like widespread socialism and universal health care. Like it was really a tough fight. And our bill also died twice in Assembly appropriations. Every consumer group supported this bill. Every single one. Because consumers understand the experience that they're having. The only groups that opposed this bill were health plans.
So I'm curious because the data transparency thing comes up a lot. Like for many years, there's been a shortage of good data about who's getting mental health treatment. Do you guys Elisa, is this something that you thoughts on? Like where the fix is? Is there a fix? Is it gettable?
I have a lot of thoughts. Well, I think to start with, you look at, I know right now the current administration is really looking at accountability and really focusing in on counties for a number of different initiatives. One of the things that counties will be doing in future years is reporting on outcomes. They will be showing their data, how much they're spending on mental health care, substance use care, with children, with adults, by different levels of care. And unfortunately, however, as Ms. Francis was saying, we don't see that on the commercial side. And similar, I have anecdotal stories about individuals coming in, that's the same thing. We don't have that data. We do work closely with the Department of Managed Healthcare, and they say the same thing. They're like, we want to help consumers. But that transparency piece is just not there for them. California is embarking on addressing some really bold behavioral health goals, including decreasing deaths by suicide, increasing quality of life, decreasing untreated behavioral health conditions, and they're really looking at this statewide. However, to this point, we don't have commercial plans at the table, and they insure over half of California's population right now. And so while county behavioral health is at the table, and soon our managed care plan partners will be at the table, they are responsible for providing what we call in Medi-Cal non-specialty mental health services. We will have an opportunity to kind of get there, but that's still only 40% of California's population. So trying to look at moving the needle for these outcomes that we all agree with. I don't think anyone would say we don't want behavioral health conditions to be treated, at a high level. We don't see that yet for commercial plans. We have started to suggest to the state that we do have dashboards showing how much is being paid for different types of services, even just by levels of care, for outpatient, inpatient. And so far, we are continuing to advocate, but there is definitely a lot more that California could do.
And I will mention that when I was reporting my most recent story on insurance denial, both the Department of Managed Healthcare and the Department of Insurance said that, by statute, they don't have statutory authority to collect this data, and that has made me wonder whether that is something that could be granted to them.
Yeah, so they don't have statutory authority to collect this data. The follow-up question is, why don't they? When bills come before our legislature that want to collect this data, why is it defeated time and time again? So frankly, that is a cop-out. And it's a cop-out for a few reasons. When we encourage health plans, because I want health plans to be a good actor here, there isn't a very big desire for them to open their books and report the data. They're not raising their hand and saying, you guys are absolutely right. We should release this data. It would make things so much easier because we're not bad actors here. That's not what's being said. And so if DMHC says that to me, I say, guys, I can't even tell you how many bills have been run that are similar or adjacent to better data collection. And the price tag on them is always high, right? We talked about the price tag earlier. And I'm not saying that it is not expensive to hold plans accountable, but what I am saying is we need to figure out where we want to spend our dollars, because we're either going to spend it on the front end or the back end. We're either going to experience mass loss when it comes to not being able to serve our families and our people, or we're just going to pay for having better data and better treatment.
I did ask a number of health plans if they would join us today, and unfortunately was not successful. It's not that we didn't want them here to sort of give their perspective, but I know in conversations that I've had, well, they do say that they are complying with the law, and also they bring up the mental health provider shortages a lot as a challenge in terms of providing treatment. And I'm curious what you all see in terms of provider shortages and how, is that a fair defense?
I don't see provider shortages.
You don't?
In California?
Okay.
I think you can pretty much, depending on whether you have really good insurance or you have Medi-Cal, or you can get treatment. The question is, what kind of treatment? And the question is, like in our case, who are the doctors who you're relying on to decide whether or not a patient needs more treatment? And isn't it related to your bottom line rather than to providing the care that a patient needs?
Yeah, so provider shortages are real, but it is not a great way to have the conversation if you're not also going to talk about what you are paying for providers. So I have heard from plenty of providers, maybe some in this room, who are very clear that the Medi-Cal payment for mental health is better than the commercial plan payment for mental health. That is something that is fixable. That is not just this random problem that we're waiting on the universe to solve.
I was just going to add that I agree that is not a good excuse at all, because everyone is struggling with provider shortages. I think one of the things, to LaShawn's point, that we see a lot is because we have an imbalance of supply and demand, particularly for clinicians, is that clinicians can go open a private practice and accept cash only, and will have no problem filling up their practice. And so that is where we're losing folks. And to LaShawn's point, I mean, I have chatted with a lot of therapists in my area, and they're like, the hoops to jump through to be able to even bill commercial insurance, it is not feasible, let alone how much they will give me back. And so it's understandable because our providers, our clinicians need to make a living, need to support their families too. And so this is not a big mystery. We know what we need to do. Yeah.
I also want to say that the reason why this provider shortage conversation is unique on the mental health side, as opposed to the physical health side, is on the physical health side, by and large, the conversation is about we're not paying enough, period, on the Medi-Cal side. That's not quite what we're saying on the Medi-Cal side for mental health, at least, right? I'm sure we could pay providers more. We can always pay providers more. But there does seem to be a difference here. We really invested in trying to make sure that we have a robust public mental health system, and commercial plans have been struggling to keep up with that.
I'll just give a really concrete example. With the passage of AB 988, one of the components in there was concerning mobile crisis care. So for those that are,
just explain quickly what that is.
Yes. So for those that aren't familiar, under Medicaid, the federal government gave states an opportunity to, if they were able to lift up mobile crisis care, they had requirements, including having care available 24 hours and some other things, that they would cover the majority of that federal share for the service. So they give states more money to lift this up. So California said, yes, we will do this. And we did pass legislation that said county behavioral health is the one that is in charge of running this benefit for Medi-Cal members. However, when people call a crisis line, we don't ask, who's your payer? We'll redirect you over there. We go out and we help the person. They're in crisis. And so we did pass legislation saying if county behavioral health teams respond to someone who has commercial insurance, the commercial insurance payer will pay the county behavioral health for that service. There can be no denials. They have to rely on the clinicians that are actually out in the field seeing the person and saying, if they're saying, yes, this was an emergency, the commercial plans cannot come back and say no. So county behavioral health has been doing their darndest to try to get that reimbursement. And a recent example is one of our smaller counties. Keep in mind that our smaller counties do not have, huge billing infrastructure systems. They build a commercial health plan for an $800 mobile crisis visit. Does anyone want to hazard a guess of how much they got back?
Zero.
They got something. $11.
I was close.
So, and this includes all the time spent billing. This means working through denials because almost everything is denied the first time. So just to show that even though we have legislation mandating this, it's another story for what it actually looks like. And again, that is one of the things with our public safety net, particularly for mental health, county behavioral health departments. We have this unique space in our system because we are more prominent than healthcare plans. And I think it depends on the area you live in. I'm personally from San Luis Obispo County. So, county behavioral health is more prominent than, let's say, Anthem or Blue Cross. I am not aware of any offices in our county where those folks might work. But so people do come to the county and say, I need help. And so again, we're not looking at an individual as a number. It's seeing a human being with whatever symptoms they have. And that extends to our mobile crisis services as well.
So we are in California, but we obviously are in a broader country that has some changes afoot. And so one thing I wanted to see if we could briefly touch on, because I know we're closing in on Q&A and I still have another question after this, but what do you guys think is going to come in terms of mental health access and state laws once the Trump administration comes back into power?
So I'm going to tell a story that's sort of different, but you'll see what I'm going for. So before we had this crisis about unqualified doctors denying, we had a period of time when, and still now, when specifically United Healthcare and Cigna would pay for the inpatient treatment perfectly according to the plan, like 85% of billed. And then when it got to outpatient, they delegated it to this weird company called Viant, which operated like a cult. And they would pay 10 cents on the dollar, literally, for outpatient care, which is, like, for me, the most important part of treatment, because now you are sober and you can actually absorb what you learn in outpatient, which is how to stay sober. So we decided to approach the federal government, the Department of Labor, and the department within the Department of Labor is called EBSA, and that's the employer plans. And we brought this problem to them, and he said, we want to testify and tell you what's going on. And we were lucky that they decided to listen to us because, the last Trump administration had basically decimated the Department of Labor, and there was hardly anybody working in the health insurance realm. And what I told Jocelyn the other day is you just have to be patient, because 4 years after we testified, 2 days ago, they announced they're taking over the cases. But I don't know what's going to happen when the new administration comes in and if they're going to gut the department again.
What do you guys, are you bracing for anything specifically, or you think it's all just going to carry on?
Yeah, so I think we're in a unique position with the children's space. I mean, kids have just a long history, even nationally, of being protected in federal government, regardless of which side is in the administration. That is the benefit. I think the things that we are concerned about is if we are moving towards a world where we have less accountability for big business, that is where we have concerns about who's holding commercial plans accountable, because it is a statewide and national effort when we talk about writing in guardrails for what health plans are able to do. I also see a lot of families suing health plans for lack of care. You talked about it in your article in October. And given who is sitting in those court seats can really depend on what the outcome is. So it's not all good. It's not all bad. We are sitting tight to see what happens.
Although I am told that in Washington, D.C., the one thing that everybody in the Congress agrees about is parity, because everybody has someone in the family who's been impacted.
Yeah, I think we don't talk about that enough. The fact that almost all of us, when we talk about, lived experience, it is now the point in America where everyone has had lived experience in some way, shape, or form on this.
Mhm.
So it's interesting because this is not something that only happens to poor people or only happens to Black people. This is something that really has impacted every facet of society. We just saw our president's son struggle with this. That is unheard of.
I think I'll just add, I do think that, particularly here in California, we are in a unique position. Our administrations over the years have always gone for the big and bold opportunities under Medicaid. We are the first in the nation in achieving approvals for a lot of groundbreaking services. And we're actually in the process of expanding community behavioral health services through specific evidence-based practices. And we hope that will be signed any day now by the Centers for Medicare and Medicaid. But I think we're kind of in this wait and see. I know that in California we value healthcare. I feel that our state does stand with that. And while it is definitely mental health and maybe a little less substance use disorder, because we still have a lot of work to overcome that stigma, it is a bipartisan issue. However, when we come to thinking about who holds the purse strings, commercial plans, then it becomes a business decision, and that face goes away. And not to keep coming back to the number thing, but you do become a number. So I do think that while we can all agree that, yes, this is important, yes, we've all had experiences, when it actually comes down to holding folks accountable and ensuring that individuals can get the care that they need, I do think that's something that we are going to be keeping a close pulse on.
So I want to leave time for you all to have your questions answered. I was hoping to just ask you guys kind of a two-part question. You can answer either or both parts. One is something that makes you feel hopeful right now when it comes to mental health, and then the other is one concrete change, like if you could say in one sentence, what's one concrete change that you think could make a big difference if implemented right now in California? Whoever wants to go first.
I'm really hopeful about our young people, how they're talking about mental health, how they're taking control over their mental health. That is something that I think will continue in the future, and then they'll become the leaders and it'll look completely different. So I'm really excited about that. I can't wait until they retire me. That's going to be great. I think if we could get to the point where parents did not have to chase down their health plan for care, that health plans really centered families by making sure families didn't have to jump through hoops for care, that would make a major change.
So I'm going to talk about first responders for a moment. So in 2020, our Malibu State Senator passed a law that said that workers' comp could not deny the fact that firefighters who said they had work-related, job-related PTSD actually had PTSD. And they shouldn't say they're not going to cover them because they think it started when they were 3 years old. And 3 years later, they passed an amendment to that, or a second law that included peace officers. So I got called in to meet the California ambassador of first responders after I put the Malibu house up for sale. And she said, we want you to reopen it to serve first responders and give them the same high level medical and clinical that you've been giving to your actors and your Fortune 500. And of course I said no. And she said, lady, they saved your house twice. Okay. So now I have first responders, and I do, as an ex-journalist, I do exit interviews with all of them. And one of the common threads is 23 years ago, when I said I had work-related PTSD from the fire I just worked on, they told me, man up. Now they tell me, go get treatment, get well, and come back. So I think that's a definite advance, even though it's slower with the police and the sheriffs than it is with the firemen who had 3 years on them.
I think one of the things I am hopeful for, kind of in line, is that we have come a long way with stigma. Everyone does have some form of lived experience, whether yourself or a loved one. And I think we are starting to get there with substance use care. One of the things that I am both hopeful for and I want to see pushed more is the normalization of receiving care, recognizing that this is not a personal failing, and really recognizing that medical aspect. We are doing a lot in Medi-Cal, and while there was a recent piece of legislation passed regarding commercial plans not being allowed to require prior authorizations for at least one form of medications for addiction treatment, that's just one step. As we go, we're still in the midst of an opioid crisis. I know that there's a lot of individuals, particularly in our marginalized communities, that are already experiencing a lot of trauma before this administration shifts. I think that we are going to have an increase in need for mental health and substance use care even more than we do now. And so I think one of the policy fixes is, I think as we've been talking about, is just holding folks accountable in just starting with collecting the data, seeing what's out there. We have our public dollars held accountable, but us or employers paying premiums to receive certain services. I think that this is where I know I am personally very passionate of holding them accountable for our care, for the money that they receive either from our employers, from us personally. But I think that that's the one concrete thing that I think we could see to start to move this needle.
Excellent. Thank you all so much. So we have some time for Q&A. I don't know if there's a mic. If anyone...
Yes. If anybody has any questions, please feel free to raise their hand and I'll pass the microphone. We'll have 15 minutes for Q&A.
So much. Okay, there it goes. You had mentioned the state doing a lot of bold investments in mental health, and that's something that I've seen a lot, but not a lot of conversation around how the state wants to invest in workers. So have you been hearing any conversations from at least state partners or county partners about how they're going to invest in the workforce when it comes to these bold solutions? Or is that something that's kind of like in the works? We're still trying to find ways to talk about that.
And just to clarify, you're talking about our workforce, like more clinicians, more staff to actually provide these services?
At least from my understanding, there's not a lot in the actual language about how we're going to staff and how these services are going to be delivered.
You read that 200 plus page bill very well, so kudos to you for that. So the state, at least on the public side, is looking at a few different strategies. One of the ones I mentioned that California is in the process of getting a federal Medicaid waiver approved, meaning that we're going to be able to expand these different services and make them eligible to Medi-Cal members. One of the proposals in there is a workforce proposal and doing some very fancy federal waiver stuff. The state is looking to take a little bit of money and turn it into a lot to invest in the behavioral health workforce. That is still not yet finalized because, again, we're having to make those special asks of the federal government to be able to spend the money in that way. Our Department of Healthcare and Access Information, HCI, they have started to develop a behavioral health workforce strategy plan, and this is posted on their website. We have been working really closely with them. I know a lot of other advocacy groups have as well. One of the things that we have already kind of started to ask questions about is we have to start looking at investments and strategy by payer. The specialty behavioral health system in Medi-Cal looks very different than other payers. So we often use a lot of folks who are not at that license level. We use a lot of certified peer support specialists, a lot of folks with lived experience, which is what I think makes our delivery system really unique. So that's one of the things when looking at kind of California's initial goal to address this. But the HCI has some very bold proposals, and I think it's a matter of how do we implement these to make these meaningful to our providers in the state.
Hello, my name is Lizette. I'm from Assemblymember Lowenthal's office. I think my over here. I was just wondering, what is the unqualified doctor or what is the unqualified provider that is like making these
You
basically
like a podiatrist?
yes, please.
Like, can you sort of spell out a little bit that
So-
review process?
So the good news is that 5 days after SB 855 became law, the Department of Insurance and the Department of Managed Healthcare together put out a bulletin that said doctors have to use the criteria of the American Society of Addiction Medicine in order to determine length of stay and level of care. That did not happen, and most of the people who are reviewing, a lot of them are psychiatrists. But why is a geriatric psychiatrist? Why is he a specialist on a young person's substance abuse? And some of them, as Jocelyn knows, were from out of state, and it's a company that seems to specialize in denying. And I guess 10 years ago was the court case, maybe more. There was a federal court case in California, and the appellate court found that United Healthcare was guilty of violating its fiduciary responsibility to someone who had insurance through them because they listened to a denial written by one of these doctors from out of state that had nothing to do with reality. So addiction doctors who are members of ASAM, who know ASAM, are the ones who are going to be able to tell us, yes, this person should be in care for another 15 days. Or no, the person's actually ready to drop down. And usually our therapists and a doctor who's qualified agree. But some doctors are clearly just paid to say after 10 days of residential treatment, goodbye, send him to IOP. And I say, do you think he's really ready to walk by a liquor store and not go in? Irrelevant. So that's kind of what we're facing.
These are doctors who are employed by or contract with the health plans to conduct their reviews. And Joan had collected some data from a couple billing companies where some of the doctors have almost 100% denial rates. So,
And that's not just for 3 or 4 cases.
and then this gets back to the question of data, because the state isn't collecting that data. So just kind of being able to access private billing company data is obviously not a comprehensive way.
And I want to say about SB 999 that to make it stronger, I started filing what's called independent medical review requests with the Department of Managed Healthcare. And I filed and filed and filed and filed, and I won all but one. So, and my thing always was, this decision was not made according to ASAM criteria, which you said was what was required. Does that help?
Any other questions?
First of all, thank you all for what you do. I'm Ken Francis. I work with Kaiser Addiction Medicine. My question's for you, Joe. Are you hiring? Because I'd much rather be working for you than my present employer.
So I'm going to ask you a question from my patients. Do you have experience with first responders? They don't like to be in treatment with non-first responders, and they don't like to be treated by people who are not former first responders or trained as first responders. It's quite interesting. So are you a first responder?
I usually don't self-disclose, and I usually try to show compassion in winning my patients, and I'm pretty successful at that.
This is an interview
But maybe
process,
for
right
any
here,
first
folks.
responders in here that don't like working for their employer, maybe they would. Thank you.
I mean, I have to say about Kaiser, I explained to this whole group of people that, we're authorized for 7 beds. And basically that we say about the 7th bed that if we're basically full, the 7th bed will be for someone who just needs treatment and doesn't have the proper insurance or doesn't have workers' comp or whatever. And we tried to be able to take people from Kaiser that way. And Kaiser says, oh no, you have to be in network with us. And workers' comp is saying, and you should look into this. Well, if you take Kaiser, that's all we're going to pay for anybody. We can't afford to stay alive that way.
also appreciate everything that you guys have shared, but I have a question that's kind of, it's a little bit different, but the state of California audited large counties and found that LA did not seek mental health care reimbursement for Medicaid patients and underfunded the county by over $550 million annually due to their unwillingness to process the paperwork, resulting in less funds. Do you know anything about that at all? And have you heard anything about that? And
Was this with Prop 63 money? Do you know? Sorry.
I don't know.
Okay. I'm just curious. We had the same question.
Yes. It's always my question. I do not have specific details on that, but I can certainly look into that and get back to you if you want to connect.
Okay, I think we have time for one last question. Hi, my name's Indira. Thank you so much for such an informative panel. I learned so much. I was curious if you could delve more into HCI and the kind of data they could provide. It's kind of like a hypothetical question, but I know they have a lot of data on just like the healthcare workforce shortage and just where there's primary care shortages and what kinds of primary care doctors. And I was curious, like, what do you think it would look like to implement like a behavioral health kind of like landscape? Should there be like another agency doing that? I know HCI is very focused on like healthcare, like workers, or I don't know, they have to have different divisions, but I was just curious, like, what have you heard from HCI and like, what do you think it would look like to like collect that data and hold those commercial plans like accountable, and would it be useful to have like, I don't know, another division or another agency? It's more like kind of a hypothetical.
Yeah, so HCI has some amazing data products and they're always sharing new ones with us, which I'm like, wow, this is really great. But just to clarify on kind of roles and responsibilities, to have the data of who's actually, who's in network for a particular plan, that is something in the policy world we call network adequacy. That would fall under Department of Managed Healthcare to hold plans accountable for actually having enough providers to serve their members. When it comes to HCI and their data, they do have a lot of data, and we have a lot of data on licensed folks. So licensed marriage family therapists, psychiatrists. We have boards that license them in California. As I mentioned before, the specialty behavioral health system is very unique. We have substance use counselors. We have certified peer support specialists. So folks who are trained to use their lived experience to support the individual with their recovery. Not to get too technical, but on our especially mental health side under Medi-Cal here in California, we have other providers who can provide services appropriate within their scope that aren't at that licensed clinician level. So actually one of the things we have been chatting about with HCI is how do we collect that data in a meaningful way, because there is no one board licensing all of those folks. And so HCI has been really wonderful in having those conversations of what does this look like for the specialty behavioral health system in Medi-Cal. And so they have started doing some modeling. They actually have this in their strategic report. And so one of the things they do acknowledge is that there is more work that needs to be done on collecting data for folks in our care. One of the things that they've also acknowledged, and this is a lot harder to do, is sure, we know how many therapists are licensed in California, but how many are actually in network, and how many aren't just doing private pay? Because we know that we have seen that increase even more so because we have a lot of demand and not enough supply.
And this is where I do my pitch to let you know that just because we have enough therapists does not mean that we have enough child serving therapists. So the conversation generally is about serving the adults in California. Very rarely will we have a program that's focused on increasing our child serving workforce. And I always tell people, you have to want to work with kids. They are a unique population. You have to like children, and you have to want to work with children. Simply training someone to work in the space does not make that work automatically transferable to work with young people. HCI has a program right now for behavioral health wellness coaches. We're excited to see what happens with that. It is new, but generally we are always talking about being trained to work with children and youth.
I'll just add on to it because of what you said, Joan, is yes, you need the specialty, particularly for the Focus County Behavioral Health Serves. You know, our clinicians are going out into creek beds to find folks. They are hitting the pavement a lot because we don't have enough supply. A lot of clinicians can do telehealth all day, you know, or they can see folks, you know, who do not have as complex of needs. But I will give one push is we also need folks who are not only trained in doing severe mental illness, but also those who are well trained in substance use disorder, particularly at our master's level. We do not have enough of those, and I know that's something that we have continued to lift up to the state of how can we encourage this, because just because someone is licensed, they maybe had a semester or a quarter on substance use, but they are not trained in ACM. They don't come out understanding that. That's often something people have to get on the job, and so we are very passionate at CBHJ about how do we encourage a workforce that comes out of graduate school wanting to serve individuals with substance use disorders and being able to do it well.
I don't know if this helps, but our former therapist at Malibu Beach Recovery Center is now the head of Pierce College's Addiction Studies Department, and I think he's looking for new ways to expand. So you might want to call him.
I will definitely do that.
Thank you all for your questions. Thank you guys so much for traveling here to be with us today. Another shout out for Joe if anyone wants to go talk to him after. Yeah, thank you all for taking the time to have this conversation.
Yes, so we have a few minutes if you all want to stick around and ask some questions to our panelists. But thank you again for spending your day with us. For folks who drove here, the aquarium actually provides validation. So go by the exits and you can get your parking ticket validated. But thank you all again. And to the folks who were joining on the live stream, thank you all for being a part of today's discussion.